So when I completed my specialty training 8 years ago, I didn't know much about the sacroiliac ligament. I wasn't aware that it could be a source of pain. So how did I get from that to where I am now, treating the sacroiliac ligament with platelet-rich plasma? Let me tell you. My name is Mark Musson. I'm an interventional pain and regenerative medicine physician. Every year, the science of what I do advances and the way I treat patients changes. So with these videos, I want to share what I learned with those people that are seeking answers to their pain. So as a new physician, I was taught that there's only a certain amount of things in the lower back that can be a source of pain. Certain joints, the facet joint, SI joint, the discs, and the nerves. So in the beginning, I would have some younger, healthier patients with some very specific lower back pain, and I'd treat all these things that I knew how to treat, and they just didn't get better. It was very frustrating. I couldn't put my finger on the problem. Very frustrating for the patient as well, where they weren't able to make the improvement, which theoretically should have been a pretty straightforward treatment. So I knew there was something that I was missing. So I'd go to national and international conferences on pain management and also regenerative medicine, and I started to see people using something called platelet-rich plasma for different things in the lumbar spine. This was definitely first used in other orthopedic conditions like joint pain, tendon pain, and I started seeing people use this in the lumbar spine. They were using it for an epidural injection in place of a corticosteroid. So I saw different people presenting studies on these case series of epidural injections with platelet-rich plasma. I wasn't sure how my patients would respond. I wasn't sure if the platelet-rich plasma would be irritating to the nerve. You know, we're injecting something into the spine that I hadn't done before. So I wasn't totally sure about it. There was some uneasiness with it. I had a couple patients that wanted to try it. I can't remember the exact reason, if there was a reason why they couldn't do steroid or the steroid wasn't working. So we decided to use the epidural with the PRP injection, and we did see some improvement. So the PRP in the epidural space was a nice added treatment option to add to the other tools in the toolbox. But there are still a significant amount of patients that we would see that no matter what we did to them, we were still missing the actual pain spot. So over the years, going to these different conferences, hearing different people talk on regenerative medicine, they'd often talk about this doctor, Dr. Hatchett, who did a lot of this type of medicine called prolotherapy way back in the 1950s. So I heard his name come up a lot. I didn't know much about prolotherapy. I had been using platelet-rich plasma, and I knew that the prolotherapy was kind of what came before PRP, but I thought that PRP was better. So finally I took some time to look into seeing what this Dr. Hatchett did and some of the other prolotherapy treatments. And I started to see that he did a lot of treatments in the spine. He would treat mostly the ligaments, different ligaments like sacroiliac ligament, iliolumbar ligament, with this prolotherapy solution. And he had some pretty incredible responses. And so for me, as this relatively new physician, trying to treat patients, trying to get them better, and struggling with some patients that should get better, I was pretty excited to see some of these old treatments from the 50s and he was seeing fantastic relief. And these are things that I had no idea about. I wasn't doing these. This isn't the standard of care, or this isn't standard treatments for pain management. So again, there's some uncertainty here where these are things that I haven't done before. So I started testing patients that were interested in seeing if the ligaments were problematic. And the way you test the ligaments is essentially you just stick a needle right into the ligament. You could either just irritate the ligament, or you could put a little lidocaine in there and see if it feels better. As I started testing these ligaments, I started to see that there's a significant amount of patients that actually had a fair amount of pain in the ligaments. And a lot of times we would test the ligaments and the patient would say, yeah, that's my spot, that's where my pain's coming from. And that was very rewarding. So these are things that, you know, for years I hadn't been treating. So we're able to see that, you know, this is part of the missing piece, or one of the missing pieces that I was missing. So it's pretty exciting to find that these ligaments were another potential pain generator that I was completely unaware of. As I started testing these, I got more familiar with some of the ligaments, what types of pain that these ligament injuries would cause. I'd also often see that these ligaments were just part of the pain picture, involved with either disc pain or joint pain or nerve pain. So they weren't always all by themselves. They weren't always isolated. So as I tested these on more patients, I got more familiar with which ligaments were most problematic. what I saw, the two most commonly affected ligaments are the sacroiliac ligament as well as the iliolumbar ligament in the lumbar spine. And something even more exciting was as I started to treat this with either prolotherapy or platelet-rich plasma. Platelet-rich plasma I compared to pulling these little construction workers out of the blood and putting them right into the problem spot to help with repair and recovery. Versus the prolotherapy, it's like injecting these little flare signals into the problem spot to signal these construction workers to come out of the blood and come to that problem area. So I was excited to see, as we started treating the ligaments with platelet-rich plasma or prolotherapy, we had a lot of patients that had some really significant improvement. And in pain management, it's sometimes rare where we see really good, long-lasting treatment compared to some of the other things we do, like steroid injections, which give some good temporary relief, but often will wear off. We even saw some cases. We had this one 80-year-old lady, a lot of arthritis in her back. And I was like, we just thought, hey, may as well test the ligaments. We tested the ligaments, saw they were problematic, did some very simple treatments to the ligaments, and she was almost 80-90% better. So very dramatic, and again, something that's, just a few years previous to this, I was not doing at all. So it was very exciting to see an additional tool, and it's such a strong tool where people were getting significantly better. Now, this being said, not everybody has a ligament problem, so it's not something that we use on everybody, but it's something that I keep in the back of my mind as we're looking at a new patient, depending on what their pain is and how they were injured. As I learned about the ligaments and the treatments, the appropriate treatment for the ligaments, I added a very powerful tool to my toolbox as a pain provider, and I've been able to see more people get better, and I've had better success at really teasing out where the pain's coming from, especially when they've already seen other pain providers or surgeons or have had back surgery and still have pain. So it's been an exciting process to learn. I realize that there's still going to be more things to learn as the science of what I do improves and regenerative medicine advances. So make sure you subscribe. I'm going to put out a video every week to help provide information for folks that are seeking answers for their pain. Until next time.